Okay, excellent. I'm now recording. Great. So the meeting, the presentation will be uploaded. Where am I recording? Let me just make sure. Where am I recording? I'm hoping I'll be able to access this presentation, and this presentation will be shared, will be put on our YouTube channel, Fetal Mission Foundation Zimbabwe. That way, you guys can watch it over and over again. Let me just introduce myself. Um, Let me introduce myself. I'm Dr. Verenga. Um, I'm an OBGYN and also a fetal medicine specialist. So fetal medicine is that branch of medicine that of obstetrics that deals with high risk pregnancy care and also um, everything that could go wrong with the fetus in uterus. What am I sharing right now? Okay. Can you see my screen? We are good, right?
Yes.
It's written fetal immune hydrops, right?
Yes.
Okay, great. So I think we can get going now. So that's what I do. So most of my work I'll be scanning babies and also teaching in labor rounds. Um, so my main activity is to do with the care of the very complicated pregnancies that women have. Yeah, so that is a very big summary of my work, which I do. My talk is research immunization, but I thought I should just present it as fetal immunodrops because that's the eventual outcome of an intervened research immunization. So, as a way of stimulating you guys, I have this case before you. I don't know, with your experience, you're now in sixth year, obviously been exposed to obstetrics already. So a 28-year-old gravida 2 para 1 who is rhesus negative woman presented 32 weeks. Her first baby required exchange transfusion. After birth, discuss the possible pathophysiology and management. Think of this question because at the end, some of you have to attempt to answer it. So just capture this question because I'll ask you to attempt answering this question right at the end. So remember this. Then I'll go on to the next slide. Then these are possible MCQ questions. Which antibody class cause rhesus immunization? It can be asked as an MCQ. Then why is the first pregnancy usually unaffected? And what is the purpose of the Clear-Beckett test? That's another question which you guys have to think about, which you should be able to answer at the end of my talk. Then, what is the critical anti-D titer? Of course, you may be asking questions like, what is this anti-D? Or what is this titer? This will be answered in the talk. Then the next one is timing of routine anti-D prophylaxis. When do we give it? All these questions, I'm sorry, I have to turn on the fan. Yes. Now the temperature is a little bit high now. So you should be able to answer these questions by the end of my talk. Then, what are the key preventive measures for SSD and meaning of positive indirect Coombs test? What does it mean if we do an indirect Coombs test and we say it's positive? And you should be able to also know what is the purpose of the mid-cerebral Doppler in the care of the rhesus isomination pregnancies. And they should be able to know the anti-D doses that we give after 20 weeks of miscarriages and the indication for intrauterine transfusion, hematocrit thresholds. So you should be able to know this. Some of you may ask and say, why do we have to know about rhesus? This is a real-world scenario. I was sent this message on WhatsApp by a colleague 2 days ago. As you can see, I've just copied my WhatsApp message and pasted it here, where he greeted me, and I said, "Hey, doc, long time, I'm okay, and you?" Then this was his reply, "Doctor," this was the doctor, "I'm fine, thanks. I have a rhesus negative mother who is already sensitized, lost 2 babies to hemolytic disease already. Want to know what her chances were under your optimal fetal monitoring." Of course, he doesn't know that we are doing interventions, but it's part of what you are going to learn today, to say we do not just monitor, but we intervene for this kind of babies so that they do not develop life-complicating anemia in uterus. So, yeah, so this is a real-world scenario where this is a doctor from out of town who sent me this message 2 days ago. But after being faced with a mother, by a mother with all this kind of very terrible pregnancy history. So yeah, so these are your learning outcomes that at the end of this talk, you should be able to explain the genetics and the pathophysiology of rhesus isominization. You should be able to describe fetal maternal hemorrhage and sensitization. Let me bring out the pointer. And the identify clinical manifestations of hemolytic disease of the fetus and the newborn, and outline preventive strategies. The anti-D prophylaxis should be able to interpret indirect Coombs test, and Clay-Bettick and MCA Doppler, and discuss management of sensitized and unsensitized pregnancies, and recognize indications for intrauterine transfusion. So that's the purpose. Then if we go to the historical background, you can see that this is a very old disease that it was given so many names. Starting in 1609, when a French midwife discovered and reported on the hemolytic disease in a set of twins. Although I'm not very certain whether this was a hemolytic disease of the newborn, whether they were not tested, then I'm just thinking maybe either she described TEPS, it was a severe form of TEPS, but you never know. But because there were no advanced testing during that time, mostly in twins, was the most commonest complication that would give anemia to one twin and polycythemia to the other is a term called TEPS, twin anemia polycythemia sequencing. Then in 1932, Diamond Lee's police later described a term called erythroblastosis fetalis. This used to be the way, if you go into the library, the old books are still there, you are going to find this books written this term here. Then Lanston and Venner discovered the rhesus blood group in 1940, and in 1953, Chon confirmed the pathogenesis of rhesus early immunization. And in 1966, that's when the anti-D immunoglobulin prophylaxis was demonstrated. And in 1971, 25 micrograms of 125 international units per 1 ml of fetal maternal hemorrhage of pegged cells or 2 ml of whole blood was recommended by WHO. So it's an old disease that has been there. And the pathophysiology stems from understanding that there are many blood groups, which I think you were taught in your pathology lectures, that we have these antigens that cover the red blood cells, and these antigens are what gives the blood groups. And there are many of them. We have the ABO, the rhesus, the KO, the MNP, Lewis, Lutheran, XG, YT, Jombrock, Cotton, public antigen, and private antigen. All these may be found on the surface of the red blood cells. So these antigens appear very early in utero. By the end of the 5th week, between the 5th and the 6th week of intrauterine life, they will be present. That means the red blood cells will have this identifying code between the 5th and the 6th week, which is 40 days. Most of these antigens have been associated with hemolytic disease of the newborn if there's a discordance between the mother and the fetus. However, most of the ABO rhesus blood grouping comes from most of the hemolytic disease comes from the ABO rhesus blood group, which accounts for about 98%. What's going on there? I think the individual needs to be muted. So this is how it works, really, to say if a rhesus negative mother happens to be married to a rhesus positive man, the man could be homozygous and heterozygous. I'm assuming you guys know what homozygous and heterozygous is, considering your stage of learning now. So if the man is rhesus, if homozygous, and the woman is rhesus negative, the chance that they will have a baby with red cells that are covered by the rhesus D antigen is close to 100%. Remember, because of penetrance issues and so forth, it is never 100%, right? But the chances are so high that the baby is likely to be rhesus positive. If the father is heterozygous, that means there's a 50% chance that the baby they are going to have will have the covering of the rhesus D antigen. The problem with this is that the mother doesn't recognize them. So because the mother doesn't recognize them, the mother is likely to form antibodies. For a previously sensitized mother, the first antibodies to be formed, the first will be the IgM antibodies, not the IgG. Then if she's sensitized further, then we are going to have secondary response where a lot of IgG antibodies will be formed. The IgM, because it's a pentameric immunoglobulin, it's not going to cross the placenta. So first exposure is not going to be to put the baby at risk. I will explain what these antibodies actually do to the baby. Just to take you through the genetics, that all these antigens have the potential to cause to form alloimmune antibodies. But let me say what we have experienced clinically so far is the rhesus and the kel. But we've not experienced others, but these are more common in other regions of the world. So whenever we are screening for hemolytic disease of the newborn, we should try to cover all these common antigens to check if indeed they are present and there are antibodies towards them. Because if we just focus on the two, we could miss babies who have one of them. So generally in most populations, for rhesus positive status, 45% are homozygous and 55% are heterozygous for the rhesus D genes. Then, like what I was saying, that the penetration is never 100% if the father is rhesus D homozygous, because there are mutations and the rearrangements that diminish the expression of these anti-D genes, the D antigen. Then the incidence of rhesus negative varies in different races, so you should always be aware that in Mongoloids it's close to nil, while in Japanese it's about 1 to 2%, in the Indians 5%, and in Africans it's about 5 to 8%, while in Caucasians it's between 15 to 13%. In the Basque region of Spain there, it can go as high as 30 to 35%. So it is very important to realize this kind of information, because it helps you to put the patient in front of you into the clinical context. In Zimbabwe, our prevalence is around 3%. Our incidence of rhesus negative status is around 3%. So it's a very small population compared to the rhesus positive. But however, cases of rhesus isoimmunization still okay, as you have seen. from the message sent by our colleagues and also from our work, which we do. So the antigen expression of these genes, if one has the gene, the expression would depend on the interaction between the red blood cell membrane protein and phospholipid molecules, resulting in a set of anti-helical epitopes. The corresponding antigens consist of this is what we'll come up with. And the antigen determinants from an intrinsic part of the red cell membrane protein structure also plays a role in terms of how these genes will express themselves. Then in terms of what happens if we happen to transfuse red blood cells to a patient, if we transfuse positive red blood cell to a rhesus negative individual, there's a 50% chance of forming antibodies because of the various factors that influence the expression of these genes. The risk is never 100%. So always be aware of this, but 50% is too high for anything. And this table shows you what women go through in pregnancy. I want you to be aware that every pregnancy has some level of fetal maternal hemorrhage that occurs. That means there's a little bit of sharing of blood between the mother and the baby. So some small amount of baby's blood goes to the mother in each of the trimesters. What you see here, this is the percentage of the hemorrhages that are observed here. You can see that the chance increases with gestational age, and these are the volumes. You can see the volume of blood that is potentially transferred or goes to the mother increases with the gestational age. So there is some low level of bleeding that occurs, whereby the fetal red blood cells go into the mother's bloodstream, and it increases as the pregnancy advances. I think we need to mute your. Do you mind, admin? Do you mind muting everyone here? If you could put this, I think next time I'll use my own channel because so that we can control how the mics behave. Right. So you can see that from second trimester, third trimester, the risk and the quantity change to increase. So this is the basis why we do some prophylactic measures in late second trimester all the way into third trimester, because we know that the risk of fetal maternal bleeding increases with the gestational age of the woman. So all these pregnancy events we see here have the potential to increase the amount of fetal maternal hemorrhage that can occur. So whenever we meet these kind of events, we need to give prophylaxis because there is a potential that the mother has been exposed to the baby's red blood cells. So all from early pregnancy loss, elective abortion, ectopic pregnancy, amniocentesis, coronary-villus amniocentesis, antepartum trauma, placenta abruption, fetal demise, manual placenta extraction, and external version. So all these events have the potential to cause bleeding that goes into the mother. So generally, the chances of fetal maternal hemorrhage are only 5%, transplacental hemorrhage to fetal maternal hemorrhage are only 5% in the first trimester, but 47% in the third trimester. And many conditions can increase the risk, as I've already shown you. Chances of primary sensitization during first pregnancy is only 1 to 2%, but 10 to 15% of patients may become sensitized after delivery. So be aware of this, that the delivery time is the biggest exposure, risk exposure period in a pregnant woman. Then ABN compatibility and rhesus non-responder status may protect the baby. Then amount of antibodies that enter fetal circulation will determine the degree of hemolysis. That is for sensitized patients. This amount of antibodies is determined by the titer. I will explain what the titer is and how it is done, and when we measure it and when it is clinically useful. Then, in terms of strategies, say how can we prevent sensitization? First and foremost, this resource incompatibility situation. Ideally, if you are in a country where the resource negative status is so high, and you're a woman who is resource negative, premarital counseling and testing may be possible, but it's very ambitious. But if you are in the Basque region of Spain, where half of the population is resource negative, this is a viable option. But if you are in Zimbabwe, where 97% of the men are resource positive, then finding the 3% of men who can marry you may be tricky. It may be a cooling task to do it. So it depends. The first one here, say how feasible is it to encourage young women who are otherwise resource negative to do that? But the underlying thing is every pregnant woman should know their resource status. Then for all women, before women go into childbearing, they should know their resource status. That means all young women of reproductive age should know what their resource status is. Then for women who escape that and they don't do it, then they should be known very early in their first pregnancy what their resource status is. This is why it is important to book pregnancy early, besides many other benefits, but so that people know what resource status you are, so that you don't get exposed to sensitized invention, nobody gives you prophylaxis kind of situation. Then resource positive blood transfusion, if it happens, then the woman should be given anti-D immunoglobulin. The quantity will depend on how much is being transfused. I'll show you the formula for doing that. Then the second thing is that when women are pregnant and they are resource negative and they have resource positive husbands, or have done fetal self-DNA test and we now know the resource status of the baby to be positive, then these unsensitized resource negative women should be managed properly. Resource, what is this anti-immunoglobulin which I said we have to give? The anti-D immunoglobulin, these are antibodies which are extracted by cold alcohol fractionation and ultra-infiltration of plasma containing high titer D antibodies. Their half-life is 24 days and persists for only 6 weeks in the mother's blood. Then 300 milligrams will protect from fetal hemorrhage of up to 15 mils of D positive red cells and 30 mils of fetal whole blood. So if you happen to give 300 mils of fetal whole blood, kind of, whether through a transfusion or something like that, then you just have to multiply by 10 here to know how much anti-D you have to give. If it is pegged cells, again, you multiply by 10. That means by 20, in this case, you need to give 15 mils of, for every 15 mils, then you have to calculate how much. If it is 150 or 300, then in that case, you may have to multiply this by 20 and you need to give 600 milligrams of anti-D immunoglobulin. Normally, the initial dose produces a weak response. So when you run an indirect Coombs test, you expect it to be within this value. So what does it mean? If you encounter a woman whose resource status is not clearly known or whose sensitization is not known, and if you run an indirect Coombs test and antibody titer, and you get a value of 1 to between 1:1:4 there, that ratio, you know that is most likely the jab they were given. But if it is higher, you know that probably this is already an already sensitized woman. Adequate doses demonstrated by positive indirect Coombs test. That's when you know that the woman is anti-D immunoglobulin given. Where some women may not respond well to these jabs, and it may be necessary to run an indirect Coombs test to just measure if they have received adequate anti-D immunoglobulin. Then we have a test called Klebetic test. We no longer use it very much, to be honest, in clinical. We have never used it for the past 5 years in our fetal medicine units, but we should know about this, that this is a test which uses acid elution principle, where hemoglobin F is known to be more resistant to acid elution than hemoglobin A, which is found in adults. So hemoglobin F can be identified by uptake of a special stain and quantified on peripheral smear. What does it do? This test helps us to measure the quantity of fetal maternal hemorrhage. Let's say in a woman who has been transfused and they're not sure how much has been transfused, you want to be able to calculate the amount of fetal blood volume, and so that you know the anti-D to give. So this is the formula: the maternal blood volume times maternal hematocrit times percentage of fetal cells in a clay bucket divided by newborn hematocrit. So that's the formula, so that you know how much how much anti-D to give in that kind of scenario. So this is the whole pathogenesis of rhesus immunization, how it plays out. To say, if a rhesus negative woman and a rhesus positive woman have a baby together, if the father is heterozygous, then there is a chance that the baby will be rhesus negative and there will be no problems. Yeah. But if either a homo or a heterozygous father happens to have a rhesus positive fetus, then in that case, when the fetal maternal hemorrhage happens, blood is going to enter maternal circulation. For a non-sensitized mother, this will result in a primary immune response. Then the primary immune response will produce the IgM. The IgM will not cross over. So the fetus will be unaffected and the mother is already sensitized. That means the mother has developed immune memory now and will be able to mount a serious response next time. So for a mother who is already sensitized, the mother will mount the immune response, which will cause, which whereby this ISO antibody IgGs will cross over, and they will bind the red blood cells and cause them to agglutinate, and they will be broken as they try to pass through the reticular endothelial system of the spleen. So there's going to be hemolysis of the red blood cells there. So this hemolysis, if it happens in utero, we're going to have in anemia, the bilirubin will increase, but it will be taken care of by the mother's liver. So there will not be a problem here because the mother's liver will take care of the bilirubin. However, the severe anemia will cause hepatic erythropoiesis and dysfunctional. This will give pressure to the portal and umbilical vein, which will result in hypertension, heart failure, where there is now third displacing of fluid. This is the Hydrops picture. This is how it evolves now. This is the condition which is called erythroblastosis fetalis or Hydrops fetalis. If nothing is done, then you are going to end up with intrauterine fetal death. After birth, this is how it plays out. The jaundice, because the maternal liver is not there, and we have a neonate liver which is immature to handle all the jaundice. So there's going to be jaundice and kernicterus and hepatic failure and death if no intervention is done. So the birth of an affected infant will result of an affected infant will have wide spectrum presentation depending on the severity of the anemia and the amount of bilirubin. But if nothing is done, this is the pathway we end up with. So that's the pathology of the isoimmunization. So how do we then manage the unsensitized pregnancies? I've already told you some of the measures that whenever women come, we need to know their blood group, including that of their husband. But nowadays, because of fetal cell-free DNA tests, we no longer rely on that alone. We can do fetal cell-free DNA tests, whereby we take the mother's blood. We now know that within the mother's blood, there are small pieces of the baby's DNA there, and that DNA will be able to to be tested and to be able to know whether she's carrying a rhesus positive baby or not. That is the modern way of doing it. The issues of testing husbands who may not be the fathers in certain cases can prove to be tricky sometimes. And sometimes you may end up opening a can of worms, right? Because if the father discovered that she is actually rhesus negative and the baby is rhesus positive, it will cause also kinds of complications that will put the doctor in between, which we try to avoid sometimes. If husband is positive or heterozygous or the baby is positive, then we're going to give, first of all, we do indirect Coombs test to the mother to make sure she is not sensitized. If she is not sensitized, then we go on to give the anti-D at 28 weeks, 34 and 36 weeks. However, we should always repeat the indirect Coombs test throughout to just make sure she is not sensitized. Then for so the anti-D immunoglobulin is given at 20 from 26 to 28. Then after every 6 weeks, we give it, and also at the time of delivery. Once they are positive and sensitized, we do not give 300 micrograms. That's an error there. Once they are sensitized, we now need to monitor for evidence of fetal anemia. In the event of any of these conditions, we need to give anti-D in the following doses: abortion, ectopic, miscarriages, coronary velar assemblies, amniocentesis. We do these procedures in our units here in Zimbabwe, like amniocentesis. We do quite a number of intrauterine procedures. So any exposure during these procedures will result in us giving this the jab. The anti-D immunoglobulin is also called ROGA. So any of these pregnancy events also warrants giving the medication from amnios, syndesis, abdominal trauma, fetal maternal hemorrhage. Then at birth, cord blood for ABO and rhesus typing is taken, and a direct Coombs test is run on the baby to look for any evidence of agglutinated red blood cells. If the baby is rhesus negative and then the direct Coombs test is negative, then if the baby is negative, it's fine. But if positive, then a direct Coombs test has to be done. If it is negative, we are happy. If it is positive, then we know that the baby will need treatment. Yeah, so that's why the indirect Coombs and the infant direct, I've already mentioned this. And then if the baby is affected, then that's where the issues of bilirubin estimation comes into play, the issues of phototherapy and so forth. That's when the neonatologists will come in to manage. Then the prophylactic anti-D, I've already told you when it is administered. Right. Then for a sensitized mother, what do we do? First of all, we have to establish how she was sensitized. And these are some of the causes here. If a rhesus blood group is interpreted during transfusions outside pregnancy, she can be sensitized by being given rhesus positive blood transfusion. Or if we do not protect a rhesus negative pregnancy, or if we give an adequate dose or improper use of IgG, or immunization to cross-reacting antigen may also cause to be sensitized. Once a woman is sensitized, there's now a real risk that if the baby is rhesus positive, the antibodies could cross over and attack the baby. Once they are attacked, there's going to be hemolysis, because these antibodies will cause the red blood cells to agglutinate and they'll be destroyed by the reticuloendothelial system in organs such as the spleen. And this will result in anemia. So once we know that the woman is sensitized, what do we do? Normally, these women should be co-managed together at the fetal medicine unit, because this is our work. That's what we do. So the woman will need close surveillance. Most of the monitoring, if it is within the fetal medicine unit, we are going to monitor this woman serially by doing mid-cerebral artery Doppler. But if it is outside the fetal medicine unit where you do not have access to the Doppler facilities, Then serial antibody titers are done for IgG antibodies positive cases. A titer is what we call a critical level, which will require referral to the fetal medicine unit. If you are dealing with the anti-D, the moment you surpass 1 in 16, you need to start referring to the fetal medicine unit because the chances of fetal anemia will increase beyond this titer. When it becomes 1 in 32, invariably these babies will begin to have fetal anemia. What is this titer? Titer simply means the concentration of antibodies in the woman's bloodstream. When you are saying 1 in 8, 1 in 16, 1 in 32, a titer of 1 in 8 shows that there are fewer antibodies, while a titer of 1 in 16 shows that there are more, while a 1 in 30 is even higher, right? So, in other words, we are saying we need to dilute the plasma 8 times to neutralize the antibodies here. For here, we need to dilute the plasma 16 times, and here we need to dilute it 32 times to just neutralize the antibody. That's the meaning of all these titers. So they vary for different kind of antigens. You can see for anti-D is 1 in 16, for KL is 1 in 8, for CE is 1 in 32. The mid-cerebral Doppler, we do this using ultrasound. You can see that the fetal brain, and this is the base of the skull, and we go to the circle of Willis, where we symbol the mid-cerebral in its mid portion. And you look at the speed, this height velocity here of flow. This height we see represent the speed of flow. So anemia blood is light, so it will flow at a higher speed. So there is a formula we use to calculate what we call multiples of median. You can see this was a 32-weeker baby. And the 32-weeker, the measured mid-cerebral artery was 75 here. And if you put everything together and you calculate, you can see the mom was above 1.688, which is greater than 1.5, which represents severe fetal anemia. What is multiples of median? Multiples of median, we are saying how many times does the population median go into the measured value. In this case, the population median is 44.5, but our measured value was 75. So in other words, this value is 1.68 times the population median here. So that is what it means. So the mid-cerebral artery is a non-invasive method. It is the one that has replaced there's a test which you will find in your book where they measure some amyloid fluid densitometry, something like that. Nobody does that test anymore. It's obsolete. It's now replaced by the measurement of the mid-cerebral artery Doppler. So babies who have fetal anemia, these babies we will pay for them for intrauterine transfusion. So you can see how Hydrops present here. This is all fluid ascites on the baby. This is the liver there. These are ultrasound scan images from our unit. You can see the perinatal. And you can see here ascites. So when we are doing intrauterine transfusion, I'll just show you a video of one of our cases of intrauterine transfusion. You can see this is the placenta condensation. That's our needle. We just put on the color to help people appreciate the needle. That's the needle which is running through the woman's belly, going to the umbilical cord incision. This was a posterior placenta. So we're giving this baby blood because this baby addresses isoimmunization. I'm sorry the video is a little bit unsteady there. But that's how the procedure happens. But before we give the baby blood, first of all, we sample the baby's blood to check the hemoglobin. That's the procedure which is called chordocentesis. So the transfusion will do it either on the cord incision or within the umbilical vein, which is found inside the baby's liver. This is the umbilical vein. Yeah. So sometimes you put the needle direct into this umbilical vein and you give the blood through that umbilical vein. So this is just to show you what we do in terms of the intrauterine transfusion. This is how we prepare babies. We give the baby some analgesia and also some anesthetic drugs. You can see you give them fentanyl and atracurium so that the baby doesn't move too much and doesn't feel the pain if we go through the if we aim for the umbilical vein. Then of course we access the umbilical vein condensation or intrahepatic. Then we give all rhesus negative, CMV negative irradiated highly concentrated blood, 75 to 80, but our lab is able to concentrate it for us up to 85%. So that's the blood we give to babies, and this is how we calculate the blood to give after checking fetal hematocrit and then the target hematocrit. Then we give using this formula, and we will be targeting hematocrit of 45 to 50%. So yeah, so that's the definitive management of this pregnancy. These are some of the complications here. Pregnancy loss 0.3 to 1%. We have not come across it, probably because we've not done many cases. And yeah, and the rest are not very important complications you see there. Right. The leakage of fluid, the amnionitis, we have not come across them, but they are written in the literature that these do okay. Sometimes we do get transient bradycardia, and but it self resolves. I should have shared with you a picture. I was holding one of our indirect transfusion debut who came to see us recently. It's quite amazing. It's quite amazing. So yeah, I think this is the end of the talk. The barcode you see there. Let me see if I can, if it is scannable this way. But if you scan this barcode will lead you to our YouTube channel, Fetal Medicine Foundation Zimbabwe, where you can watch many of our talk on fetal medicine, including some of the. Let me see if it's scannable here. Yeah, it is. So if you scan that YouTube, that barcode, it will take you direct to our Fetal Medicine Foundation Zimbabwe YouTube channel, where many of the presentations that you want to of our work you'll find there. So anything you want to understand in obstetrics and fetal medicine, you are going to find it presented there, including probably some of the lectures I'm going to give you, I have not yet given you. You are going to find them on that YouTube. There are more than 100 lectures we have posted in our YouTube channel. We have given ourselves and our colleagues. So today's learning is never in the classroom. It's on the wide web. And you can do it at your own time. That's what we call student-centered learning. So with technology, this is why we will be uploading this lecture there, so that you guys can watch this lecture at 2 a.m. Nobody has to restrict you to a specific time to learn. That's an old way of learning. Even this lecture format which you are doing is also an old way of learning. Now the learning, you are adults, you should do it at your own free time. Even at 2 a.m., at 3 a.m., you should be able to watch a lecture and pose questions to us. Those are my contacts. If you guys develop any questions concerning everything I've presented, but I'll leave the room for questions now. If there are any burning questions. Yeah, so we have 5 minutes to just fumble around. Any questions from you guys, either in the chat box or anything which I've said which you do not understand? If you don't have any questions, I want you to attempt to answer these questions. So capture this question. You saw my number. My number is on WhatsApp. So because there's no time for you to answer this question, you can take my number there. Send me what your response is like on my WhatsApp number. I think you have my WhatsApp number down there. Yeah, so that's my WhatsApp number. So you can send me what you think, how you'd have wanted to discuss the first response. Then this one I might want you to post on the chat group. Right now you have 4 minutes. Which antibodies, if you guys can tackle the following, I'll give you 2 minutes to just try to respond and throw your answer in the chat. Just go through those and just throw in your answers in the chat. You have 2 minutes for this one, then 2 minutes for the other one. To just check if some learning has taken place. You never know. Yes, let's see what you guys have done. IgG, good. Quantity amount of fetal, quantify amount of fetal maternal, excellent. We need answers to everything, guys. There are 17 of you, certainly. Let's keep the answers coming. The earlier we do this, the better. So here we want the critical anti-D titer for racers here. Why is the first pregnancy usually unaffected? We didn't get that answer. 1 in 16, that's good. Here's out there. Then let's see. What is the timing of routine anti-D prophylaxis? We didn't get that answer. Let's get it coming, guys. Okay, this primary immune response, fair enough. So IgM is produced here, which doesn't cross the placenta. Twenty-six, 34. Yeah, 20, it's 26 to 28, 34 to 36, and then at the time of uh, of birth. Don't forget delivery. At delivery, when you are giving anti-D, that is the most important, and that is when the most exposure does happen. Remember this. Right. So the next one, that's the next response there. We need for the next 5 questions. Key preventive measures for rhesus D. If each one of you type one, I think you exhaust them. Then the meaning of positive indirect Coombs test, what does it mean? If a woman comes and their indirect Coombs test is positive, it means what? Then what is the purpose of the MCA Doppler? Then anti-D doses after 26 weeks miscarriage. I think with this we have the dosage, the dosage. What are the indications for intrauterine transfusion? Instead of hematocrit threshold, give us the MCA threshold here. The mom threshold for the MCA, what is it? Let's keep them coming, guys. Your time is up, but I'll give you 1 more minute to respond. Uh-huh. Keep them coming. I'm still waiting. Um, of course, time is up, but I need answers. I need answers, guys. What is the purpose of the MCA Doppler? And what are the indications of intrauterine transfusion in terms of the MCA? When would we consider intrauterine transfusion? I'm not getting answers. Does it mean all of you? No, nobody got it, right? Then what do you think below 30%? And we are looking for. What do you think? How do you think I responded to the colleague here? So MCA detects fetal anemia, fair enough. So what range would we say there's no severe anemia? What moms, what multiples of median? Would we say, look, there's no severe anemia, we need to do something about it? What identifies antibody sensitization? I don't think that one is correct. People say of what? Yeah, 1.5 multiples of median. Good, good. I'll jump. I know you guys didn't answer everything. Oh, you mean papers of ICT, indirect Coombs test? Excellent. So it identifies antibody sensitization. You are right there, Chaffee. Well done, well done. So how do you think I responded to the colleague who sent me this message? Anyone guessing? How did I respond to him? After going through the lecture, how did you think I responded to this colleague? This one I need an answer. I need an answer from someone. Because it's a real life scenario. You can't say there's no answer when somebody somewhere is suffering. There has to be an answer. Because this is a real case which is existing in Zimbabwe. Probably the person may be related to one of you, never know. Because you guys represent, probably from all over Zimbabwe. So what do you think I responded? How did you think I responded to this question, to this inquiry from a colleague? Anything else, guys? We have 1 minute. If there is no one to take it after 1 minute, we'll close the meeting. How did you think I responded? Right.
Hello, Doc.
Yes.
Okay, so when you say under optimum fetal monitoring, I would like to say the chances of having a baby are fairly good.
Why are they so good? This is a sensitized woman. What would change her chance next time? She's already lost two. What would change the chance in this case? Why, if she comes to us, why do you think she will not lose the pregnancy? She's likely not to lose the pregnancy. What would save her from losing another pregnancy? Raphael, you're thinking the right way, but I want you to be specific here. Okay, somebody's been specific. I think you told him that the baby has a better chance of survival with early optimal monitoring and transfusion intrauterine if needed. Yes, star, Natasha. Yes, star. That is exactly what I told my colleague, that look, for this woman, she needs to come and see us early. We optimize her, we monitor her, we do intrauterine transfusion when we think the baby now has anemia. That is exactly what I told the colleague. So yeah, thank you so much, guys. Enjoy the rest of the day. Bye-bye.